Welcome to this video tutorial for the placement of the right ventricular lead at the RV apex. My name is Mauro Biffi from Bologna University Hospital in Italy. The definition of an apical lead placement in right ventricle may be helped by the knowledge of right ventricular anatomy as displayed here by an RV angiogram being taken in two radiologic views. On the left panel is the left lateral view, on the right panel is the right anterior oblique view. A right ventricular angiography catheter is being placed here at the anterior prospect of the RV in the left lateral view, and is being visualized here at the RAO view at this point. You clearly understand that this anterior location being appreciated in left lateral, the sternum is here, the spine is here, may not be easily appreciated at the right anterior oblique view, where the angiography catheter tip looks somewhere in the mid of the right ventricle. This simultaneous biplane angiogram also shows a temporary wire being in place from the inferior vena cava to the apex, anterior apex here in left lateral view, and an active fixation lead being close to the apex. When you check these two leads' position in the right anterior oblique view, they look completely different. The temporary wire that is the most anterior in left lateral view is the least anterior in right anterior oblique view. Indeed, the RAO view is mostly adequate to assess what is basal from what is mid-ventricular to what is apical in the length of the RV. Whereas the left lateral view is mostly adequate to assess what is anterior from what is septal in the RV. As we will see later, this is mostly important when the assessment of the apical, anterior or septal location of a lead is needed. This is the situation that we were assessing before. What looks apical is different depending on the radiologic view that we are considering. And especially, right ventricular angiography helps us to identify where is the septum. This is the septal location of the lead, which is perpendicular to the major axis of the ventricle in left lateral view, and is truly basal in right anterior oblique view compared to the other leads. This is mostly important when a septal lead assessment is needed. We will now observe the placement of a right ventricular ICD lead in a patient who already had mitral and tricuspid valve ring annuloplasty. The first step is shaping a stylet with a large curve that is advanced up to 1 centimeter before the lead tip. The lead is then pushed smoothly across the tricuspid valve up to the right ventricular outflow tract below the pulmonary valve. Once the lead has reached this location, the stylet is exchanged for a straight one, and we will see the maneuver in the next step. Once the lead has been advanced to the right ventricular outflow tract, the curved stylet is replaced by a straight one. The straight stylet is inserted into the lumen, and once it crosses the tricuspid plane, it is advanced up to the last centimeter of the lead. The lead is pulled back, and when it points downward to the apex, it is pushed smoothly to the apex. Again, it is normal to elicit premature beats or non-sustained ventricular tachycardias. Always remember that the stylet shall not go to the lead tip to avoid placing too much pressure that can cause inadvertent perforation at a later stage. The presence of the two rings helps to clearly identify the next step is to look at the lead position in the left anterior oblique view. Here you understand that the lead is crossing the tricuspid fully, and here you see where the mitral valve is. In left anterior oblique view, you will appreciate whether the tip of the lead points towards the anterior view of the right ventricle or to the septal view of the right ventricle. Though not being a left lateral view, the left anterior oblique 60 to 80 degrees, just like in this case it is 70 degrees, will show you that the lead points towards the observer. If it were an anterior apical placement, it would point towards the sternum that is located leftward. This left anterior oblique view is an important confirmation to prevent inadvertent perforation when the lead is too anterior. The next step is to observe the lead in the right anterior oblique view. Here the lead course crosses the tricuspid plane, and we clearly appreciate that the coil of the lead is fully inserted into the right ventricle. Another very important information that you gain from here is the detailed visualization of the radiologic features of the lead that can be important for the next steps. It is now time to move to lead fixation. After checking the signal quality and pacing threshold in right anterior oblique, we can screw the lead. This is the most important view because all the radiologic features of the lead are visible. This Medtronic lead has three markers in the unscrewed status. One marker at the tip, one at the ring, and one at the middle. After 9 to 10 turns, this will change, and only two markers at the tip and at the ring of the lead will appear. Now two markers only are visible. This translates into screwing the lead to the heart muscle. And by signal check, we will easily realize that a current of injury is detected. Have a look at the signal now. and see the current of injury. Current of injury is there. Nice, good signal. Pacing threshold. Next step is to pull back the stylet here so that it is at a tricuspid level, and at this point the lead needs to be pushed until it buckles. If proper fixation has been achieved, the tip of the lead will not move and the lead cannot be dislodged. Here we see the test again. Pull back the straight stylet, then push the lead body until it buckles towards the RVOT. This is completely different with Brady leads that do not have radiologic markers. In this case, the screw is coming out upon rotation of the clipper without any change in the radiologic appearance of the lead. You clearly see the screw out. Then the same test is applied, and being the Brady lead softer and lighter, you can loop the lead body while the tip of the lead holds steadily in place. Again, once lead stability has been tested, it is time to rule out extracardiac stimulation. The signal will show a huge current of injury, and extracardiac stimulation is ruled out by pacing at 10 volt either in unipolar or bipolar pacing configuration. Lead impedance shall be within normal range. Afterwards, a pacing threshold is measured, and when it is acceptable, the lead placement can be assessed as optimal. In this case, during the acute lead testing, the threshold is below 0.8 volt. So, being the impedance in the normal range, the implant can be accepted. Coming back to our ICD lead placement, we will take the same steps as described above to ensure that no extra cardiac stimulation occurs and the signal quality and the pacing threshold are fully acceptable, as in this case. Signal, amplitude and pacing threshold are within the acceptable range, pacing threshold between 0.5 and 0.6. These few steps are needed to ensure optimal lead performance either acutely and at long term, specifically pacing threshold increase and avoidance of lead perforation. Passive fixation lead do not behave differently in terms of lead positioning. A large carved stylet is used to cross the tricuspid valve that has to be passed through by gentle and smooth push, and then a straight stylet is inserted following the same steps as an active fixation lead, pulling back the lead until it points towards the apex, gentle push with the stylet 1 centimeter far away from the lead tip. And the same rule applies also to passive fixation leads. In summary, very few basic steps are needed to ensure a safe and effective placement of the right ventricular lead at the apex. Firstly, shape a large carved stylet to cross the tricuspid valve and reach the right ventricular outflow tract. Then exchange the curved stylet with a straight one to aim the apex. Pull back the straight stylet 1 to 2 cm from lead tip before aiming to the apex. Push gently, then check electrical parameters to verify good contact. Check the lead position in left anterior oblique 60 to 80 degrees and right anterior oblique 30 degrees to confirm the septal side placement of the right ventricular apical lead. Consider a location change in the event the tip of the lead points anteriorly. Only after these steps screw the lead in right anterior oblique view. Remember that some leads need radiological markers to ensure proper screwing, whereas some others enable direct visualization of the screw extrusion. Once screwing has been completed, check electrical parameters. Pull back the stylet to the atrium and push until the lead buckles to ensure lead stability and absence of perforation. Rule out diaphragmatic stimulation by pacing at 10 volts, then measure electrical parameters to confirm an optimal lead placement. Following these steps will help to achieve the best lead performance and to prevent inadvertent right ventricular perforation. Thank you for your attention.